people who freeze their eggs need to know that, number one, there's no number of eggs that can guarantee a baby. And number two, you might need to do multiple cycles to kind of reach your fertility preservation goals. So I think if we educate people about this option, but that there's not a guarantee, then we're empowering people with the knowledge to make their own choice.
Welcome to the Unaparent podcast, the place that delivers deeply human stories about the unapparent truths of parenting. My name is Katia Lindor, and I am your host. Join us as we debunk myths surrounding parenthood and provide an empathetic, judgment-free space for parents and parents-to-be. We hope you enjoy the show. Hello, everyone. Welcome to another episode. Today's remarkable guest is Dr. Randi Goldman. She is a reproductive endocrinologist and infertility specialist who serves as the program director for the REI Fellowship at Northwell Health, shaping the training and expertise of future fertility specialists. Her clinical and research interests span a broad spectrum of reproductive health topics. Dr. Goldman is deeply committed to improving fertility treatment outcomes, expanding access to care for underserved populations, advancing fertility preservation techniques, and providing compassionate, inclusive fertility care for the LGBTQ+ community. Her pioneering work on, can you help me with that word?
Yes, oocyte.
Oocyte. That is a word I just learned. It's basically egg freezing, right? Has been widely recognized, featured in publications like the New York Times and the Washington Post, and has significantly expanded options for women and families. So I might have butchered some of that, but if you want to add or correct or just say anything else about your impressive resume, basically.
No, that was perfect. Thank you so much, and thank you for having me. It's really exciting to be here. I am a reproductive endocrinologist, and I love what I do. I think I have the best job in the world. And I try to dedicate my time to expanding access to care and making sure that people who need and want to utilize fertility services have the opportunity to do so.
Amazing. So Randi, before we get into your actual work, can you talk a little bit about your personal experience in your own pregnancy? You know, you're a mom of two boys, ages 6 and 3, correct?
Yeah. Yes.
So what was your experience like as a, mom and having the job, the career you have?
Oh my gosh, that's a great question. So I have two boys, 6 and 3. And I actually got pregnant with my first when I was still in fertility training. And I think that, being exposed to individuals and couples who are struggling with infertility, when I didn't get pregnant right away, I got nervous. And so it's not exactly evidence-based, but when I wasn't pregnant in 3 months, I kind of did a workup on myself and actually found something that had to be addressed prior to getting pregnant. And I'm really glad that I did. And I think that helps me now with knowing if people kind of have an intuition that something might not be right, that you can request a fertility workup right away. You don't have to wait if it's something that you feel is important to know now. But I thankfully had an uncomplicated pregnancy and delivery when I was still in my training. And, nursed for a while afterwards until my older one was, about 1.5 years old, a little longer. And then when I was an attending physician now at Northwell, I wanted to have another baby. And so I already kind of knew that this thing might have to be addressed again, which it did. And then, quickly got it addressed and then was able to conceive my second son and had two, thankfully, knock on wood, very uncomplicated deliveries and pregnancies, and was very thankful for that. It was elevated prolactin, which is actually responsible for making breast milk, which is probably why I had no trouble with nursing. Mm-hmm. I had a huge oversupply, but
I've never tested myself, but I've always and this is something I really want to talk about eventually with someone who's maybe specializing in breastfeeding. But so many women ask me how do you have enough, make sure that you have enough milk and whatever. And I sometimes feel guilty because I've never had a problem issue with it. But I also question how much is it that women are told that they don't produce enough. And so they just believe it.
Yeah.
And they probably do. And then so they push formula onto them.
My own pediatrician, who I no longer go to, was that. And because I had such an oversupply with Julian, my first one, I knew that I didn't have to wake up every 2 hours in the middle of the night with Caleb, and I didn't. And I mean, I try not to tell it because it's hard. A lot of people have to do that. I didn't have to, which I was lucky. I recognize I was lucky, but I actually think it's because I have the prolactinoma. Like
I might too. I might too, honestly, because it's one of those things where it's like I've never gone and checked, but I've always been able to produce
just direct
not only
feed.
Enough, but like
I also
probably
did a lot of skin to skin.
Same.
I
think I followed
but
my intuition, and I carry my children are always on me.
Yeah.
And I feel like that
it helps
because obviously if I had to like leave them and go work or go out, or I would just have that separation, maybe my body didn't know to produce enough for them. And I think we're meant to have our children on us at all times when they're at that age.
Yeah.
And that's naturally going to increase your supply or keep it at where it should be, right?
I had my research year when I had Julian, and so I was able to be home a lot. And I also think that really helped.
Yeah.
And then when I was in the office, because we were in a hospital, I sort of had a hospital grade pump like at my disposal, and I had a private space, and I had, a refrigerator in my office, and I would look at pictures of him or videos of him, and it would help just, immediate letdown.
Right. Yeah.
But I recognize that not everybody, is able to do that. But I feel very fortunate that I was able to, exclusively nurse both kids, while working, while training.
I think it takes both the desire, right? I'm not saying that women who have the desire are always able to, right? But in a work environment, it's just, I guess, so important for your work environment to allow that, right?
Yeah.
And not just the logistical aspects, but in a way that's like promoting, you're a breastfeeding mom. You have your own space and time, and you can do this, and it doesn't feel like you're, I don't know, like an alien in this space.
No, and it also can't come off as like it can come off as something as a burden to ask. And as the program director for a fellowship where we have trainees who are of reproductive age, many of them have children or want to be parents and are pregnant, and I think the onus is on us to really say, like, what do you need?
Right.
Do you need the time, the space, the flexibility to, say, pump if your baby is not here? And I think it's hard because there's a lot of kind of older thinking that you're taking time away from working, you're taking time away from patients, when in reality, we know that people who are parents and people who are mothers are generally better doctors. So we need to allow them the space to have the time that they need to take for themselves and for their children to nurse, right? It shouldn't be like, oh, you're taking 15 minutes to pump. You owe me 15 minutes at the end of the day. That's not okay. They just need the 15 minutes to pump, and they will get their work done.
Right.
Despite that,
I feel like if anything has been proven, it's that mothers are like master multitaskers and they can do a million things at once and do it well.
Yes.
So I think there's no more evidence that you should allow that, and that it won't hurt the work aspect, right?
It'll help.
It'll help, right?
Yeah,
because your mind isn't like on like, oh my gosh, I need to do this. I feel uncomfortable. My baby, this and that, like a million things.
Yeah. And in the OR sometimes when you're operating for hours and you're like feeling so full, and then you don't want to bend over and then have like, if you're wearing one of the freebies, like milk come out. I mean, listen, it's happened. But I think it has to be normalized. It has to be talked about. The expectation is that people should have the time to do the things that they need to do. That could be breastfeeding, it could be pumping, it could be going to a doctor's appointment. Like there's so much of it that I think we have to consider people as a whole when we're working with them or training them or they're learning from us. And things like that.
when these systems are set in place, right? Mothers need to be thought about, like, because if the space wasn't thought about beforehand, it's a little harder to implement after the fact when they're afterthoughts, right? When mothers and children are, oh wait, they might be members of society too. Let's try to fit in something for them. But then like the system is not, it's not for them, right? And so it works
100%.
Against them, unfortunately, many times. And, talking about becoming mothers, right? And going back to our conversation on fertility, one of the most common fertility options, right, out there, or that at least I've heard about, I think most women, is egg freezing, right? And it's become this, I don't know if it's a more recent boom where you enter your 30s, and like, I know every woman that I know who's in her 30s has either already done it or have been thinking about doing it, right? So what do you think about egg freezing as an option, and in what ways do you think that its marketing might be misleading nowadays?
It's a very good question. So I have done a lot of research on egg freezing, and I'm a big proponent of telling people that it's an option and educating people about their fertility and about what they can do to potentially preserve their fertility if it's right for them. And people in their 30s, the fertility starts to go down. It goes down more, after the age of 35 than in the early 30s, although it can start a bit earlier. And I think it's a really powerful technology for the right person.
Mm-hmm.
It's not that everybody who's in their early 30s needs to do egg freezing or should think about it. The likelihood of having infertility in general in the population is somewhere between probably 1 in 6 or 1 in 8, depending on kind of the study that you're looking at, which means that most people, thankfully, are not going to have infertility. Either 5 out of 6 people or 7 out of 8, depending on where you're looking, are not going to require any fertility treatment. For people who are pretty sure they want to have a biological child, and it's not something that's necessarily on the horizon, I think it's a good option to educate about. But there are a lot of limitations to the technology, and I think it's really important that we tell people what egg freezing can do, but equally as importantly, what it can't do. And it's not that egg freezing can prevent infertility. It's just another tool that could potentially allow a person to have a biological child later in life. But there's no number of eggs that can guarantee a live birth. And there are most people who freeze their eggs who won't need to return to use them because they won't have infertility. And so it's really not an insurance policy. There is no guarantee. And I think it's really important that we tell people who do egg freezing that there is a risk of regret. It's a costly thing. Very often it's not covered by insurance. And so there is a good chance that you freeze those eggs and you never need to use them, either because you decided not to have a child, which is perfectly fine, or because you wanted to have a baby, a biological child, and you didn't have trouble. And so I think that people who freeze their eggs need to know that, number one, there's no number of eggs that can guarantee a baby. And number two, you might need to do multiple cycles to kind of reach your fertility preservation goals. And more likely than not, you're not going to need them. So I think if we educate people about this option, it's another tool that can potentially be used to have a biological child, but that there's not a guarantee, then we're empowering people with the knowledge to make their own choice. Mm-hmm. But do I think it's right for every single person walking through the door? No. Mm-hmm. I think it's really a very personal decision. And when we counsel people about this, it has to be in a personalized way.
Right. Yeah. I mean, that financial aspect is just such a huge one to consider, right?
Yes.
Solely that for many people who maybe just it's a lot more burdensome for people whose financial situation is just you're stretching it to be able to make this choice.
Yes.
And I think if the belief is that this is going to ensure that I'll have kids no matter what, people are going to go for it, right?
Yeah.
And so, as you say, knowledge and just being informed and educated about it so that pros and cons to make the best decision for you is just so key.
Definitely. And there's been a lot of talk about, if we're offering this technology, are you encouraging people to have children later? Mm-hmm. And are we telling people that they're definitely going to be able to conceive a pregnancy when they're 40? And I think that there's going to be some truth to that, right? A lot of people who treat people with egg freezing, there's a financial incentive for that, obviously. Mm-hmm. So I think it's really important to know, who is giving you the advice and where it's coming from. And obviously with social media, people are much more open about their egg freezing journeys at this point. Mm-hmm. But, finding a team that you can trust to kind of go through the pros and the cons is critical.
And what can you tell us about IVF? And I know that it's a lot more common nowadays that women are going through this process, and maybe because it's can be a really difficult process, there's a lot less talk about it. And I think it's important for people to, be cognizant of what it is, what women go through when they're going through this, and, all of the pros and cons as well.
Yeah. IVF is certainly not an easy road. Mm-hmm. It's pretty intense. Oftentimes, a single cycle is not necessarily very long, but does involve things like injection medications that a person is typically giving to themselves over about a 10-day time frame. and goes into the office every couple of days for what we call monitoring, which is essentially blood work and ultrasound. And people in couples who do IVF very often have different types of infertility. So they could have significant male factor infertility, like issues with the sperm. They could have issues with their fallopian tubes. They could be a bit older, have a low number of eggs in their ovaries. Those are kind of the common reasons that people do IVF, plus some genetic reasons that people choose to. But it's not an easy path. It's a lot of doctor's visits. It's also not a guarantee. And I think that can be hard. You can go through this whole very time-consuming, sometimes very expensive process, and at the end of the day, not have a baby, which I think is really challenging. After injection medications, a person has an outpatient procedure done under anesthesia. That's called an egg retrieval, which is where we drain the follicles where the eggs are in the ovaries and collect the eggs, put them together with sperm outside the body to make an embryo. And then that embryo is put back into the uterus. And very commonly, people choose to do genetic testing on their embryos first to see if they are healthy and genetically normal. And, if you, in a good lab, if you have a genetically normal embryo, the likelihood of having a live birth per embryo transfer is probably somewhere around 60 or 65%, which is great. It's a great success rate. It also means that 35% of people, 40% of people don't have a baby with a transfer, which is not a small number. So I think, kind of similar to egg freezing, it's really important to talk about the limitations to the technology, that it's not perfect and that it's not a guarantee. But yeah, IVF is definitely becoming much, much more sort of common, at least from my perspective, as I'm seeing, lots of patients come into the office struggling with fertility.
And as I understand it, you have a fertility calculator. I know that's a question a lot of people want to know, about like, how do I know, if I'm fertile or how fertile I am and this and that.
Yeah. So my calculator is an egg freezing calculator that is based off of research that I did when I was a fellow in training. I was at Brigham and Women's Hospital, which is part of Harvard Medical School's kind of hospitals there in Massachusetts. And it's kind of my favorite research. One of the things that we were seeing all the time were for people who were doing egg freezing, saying, well, how many eggs do I need? And if they did a cycle, should I do another cycle? And so this calculator predicts the likelihood of having at least 1, 2, or 3 live births based on a woman's age and the number of eggs that they have frozen. And it's based off of a lot of patients who actually went through IVF cycles, and it used information about the likelihood that you would have a genetically normal embryo based on that person's age at the time that they're frozen. And it was incorporated, this research was published in a journal, and then MD Calc, which is a medical calculator kind of company, reached out to us and asked if they could make it into an actual calculator for people to use, which is really exciting. And it's totally free for anybody to use. It's widely used all over the country and the world at this point. And I tell patients about it. People have incorporated it into like medical records, which is very cool to see. But it was really important to me that it is free and available, and that this is really just a tool that people can use to sort of for counseling and to increase the knowledge about what they actually have frozen. Like, they want to know, what's my likelihood of having a baby? If I am 34 and I have 20 eggs frozen, the answer is at least 90% for at least one baby.
Okay.
But, to me, it's very tangible. It's research that really has a purpose. And it's definitely my favorite research that I've done.
I mean, you're very modest. Like, we have a genius in our presence here, basically. That's incredible. And so how much is age a big influence in your fertility rate, I guess? That's a question I personally have because I don't know the answer to that.
Yeah, it's a great question. So age and fertility have an exquisitely sort of sensitive relationship to one another. And that's because we think that women are born with all the eggs we're going to have. And so when we are in utero, when we are fetuses in our moms, we've got somewhere around 6 to 7 million eggs. By the time we're born, that number is already down to like 1 to 2 million. When we're in puberty, when we hit puberty, it's about 400,000, and women will typically ovulate about 400 eggs over the course of our reproductive lifespan. So that's like a tiny fraction of the starting follicular pool. So what happens is over time, we lose eggs. It's not only the one egg that we ovulate, we actually are losing hundreds of eggs every month. The one egg that we ovulate is kind of like a spit in the bucket compared with everything that we lose.
Mm-hmm.
And so that's one part of why kind of age matters. And then the other part is what we talk about egg quality. Egg quality is sort of this nebulous term that really means the percentage of eggs that are expected to be genetically normal. And that number goes down with age. Starts in the kind of probably early 30s and then decreases more appreciably around the age of 35 and 37, and then kind of steadily declines until, the natural age of menopause in the U.S. is about 51. Mm. And so when we talk about low egg quality, we mean that the number and percentage of eggs that are normal in our ovaries decreases with age. And so if you have an abnormal egg that gets fertilized by a sperm, you're left with an abnormal embryo. Mm-hmm. And that's why fertility goes down significantly with age.
I see. And this is women, right? So I want to talk a little bit about how, society has just generally placed the burden of fertility on women, right? Even though I think research does show that a lot of consideration is, the male aspect of infertility in this equation. So what can you tell us about, I guess, why, first of all, that is, why males aren't necessarily faced with all of these options to raise, I guess, their fertility opportunities, and also in what ways do you think that could change?
Yeah, really good question. So I think the burden is placed on women all the time in society when it comes to childbearing.
Right.
Probably because of just inherent biases that come in our society, which is completely unfair. And because, women are the ones that are carrying the pregnancy. What we know in real life is that at least 40 to 50% of couples that are coming in with infertility have some contribution of male factor. Mm-hmm. So yes, women matter in this, right? Like women's age and eggs matter and egg quality matters. But sperm also really, really matters. And I think it's also not really fair to the men to kind of discount their infertility as well. But really, I think men are less likely to talk about things. Women tend to be a bit more open just about emotions and what they're going through on a day-to-day basis. But we know that men have a huge contribution to fertility as well. Mm-hmm. And sperm analyses and sperm quality has really gone down over time. And we see this time and time again in studies where if you compare a semen analysis from many, many years ago to like the average semen analysis today, sperm counts are going down, sperm quality is decreasing. That's probably multifactorial. It's probably like environmental and sort of exposures and things like that. But when we do, a fertility workup for a couple that's coming in, the rule is that both partners get a workup at the same time, because you don't want to do an entire workup on, the female partner and then kind of make a plan only to find out later that there's also an issue with the sperm. Mm-hmm. It's not fair to the individual. It's not fair to the couple. But I think it really is sort of societal expectations among women, like for women, what their roles are. Mm-hmm. That things just tend to get blamed very frequently on the female partner, when in reality, a lot of times it's solely the male factor or a huge contribution of male factor. And we're not doing right by the patient at all by not including that in the discussion from the very beginning.
Mm-hmm. Yeah. And when you say that there's environmental elements, right? I've read that just like the plastic that we find in our food and in our environment is a factor. Is that correct?
I think it is. Yeah. There's not like one single study that can pinpoint the exact thing in the environment that is contributing to fertility, both from the male side and the female side. But I think it would be foolish for us to not consider the environment when we're thinking about why infertility is increasing. We know that we are using plasticizers, things like BPA are everywhere. Mm-hmm. And I think there was a study that showed that in like placentas, it's found like microplastics are found in placentas, they're found in sperm, like they're found kind of everywhere because they're ubiquitous. They're used in everything. They're ambient. And people worry. I see a lot of patients who are worried about this. Understandably, they should be. But it can't be just an individual making choices for themselves. Obviously, that's part of it. But I think that we really need to focus on like regulations about this, because it really is everywhere, and it's not possible to avoid without having, laws and regulations that at least acknowledge that environment could be a potential issue and not kind of ignore that fact.
Right. Yeah. And that goes for, I feel like, everything, right? Our environment is directly tied to, I think, our well-being, right? So it's like, at least consider that option, right?
Right. Like, even if we don't know like the exact compound that might be contributing, it's probably multiple of them. I think that we can't say for sure that it's not it just because we haven't specifically identified what it is.
Right. And I don't mean to put you on the spot, but as in the medical community, right, and going back to like the biases of like gender biases, how much do you think has to do with the fact that there's a lot less emphasis on female health in general? And that's, going back to how much of the burden is placed on women, like starting with birth control, like not getting pregnant, that's placed on women. Getting pregnant, that's also placed on women. And everything in between, right? Your decisions, your choices, what you do with, your reproductive health. And then just the overwhelming lack of resources for women's health.
Oh my gosh. So I can definitely address this. And I think about this kind of a lot. So I think that, and it's not because, male leaders are inherently bad or not thinking about it, but I think when you don't have people in positions of power and leadership to be advocating specifically for women's health research and women's health resources, I think you're going to just by definition have less of it because, again, not for any intentionality there, but, you really have to have people who are purposefully including women's health priorities in the decisions that they're making at every level. And I think that probably has a lot to do with it. Historically, there were many fewer women leaders and women who were making the decisions and advocating on behalf of other women. Like, it's just sort of natural. It's for you to advocate for a person who is another woman when you are in a position of power like that. So I think that it's a great question. It probably has to do a lot with that and just sort of societal expectations about sort of what women can and cannot do. And I think that permeates a lot of the decisions that go into kind of every day.
Yes. I mean, we could probably talk only about this for a long time, but I think we've come to that consensus. I think it's a pretty widely kind of known. Maybe awareness is shifting a little bit, hopefully, that women's health should be a priority, and it's not. And I think this goes. I want to. If there's any men listening, right? I don't want men to feel like feminism is about only about improving women's lives. It's about, no, let's have like an equal stance here where,
sure.
just as much as, men are studied and their health is important, equally as much, women's is. So
100%. And I've had amazing male mentors and leaders and stuff, but when you think about it as a whole, I think we could do better than what we're doing now.
Sure.
And, even with thinking about, clinical trials with new drugs and new things like that, women were often excluded, especially pregnant women were excluded because they didn't want to, do harm to a pregnancy, which I think makes a lot of sense in certain circumstances. But because of that, you have all of these medications that are sort of unknowns in pregnancy. Well, is it safe? Can this person take this? The answer is we don't know because we didn't let them in the trials. I'm not a doctor. I have done no scientific research, but these have been my conclusions of all of my pregnancies, because you don't really think about it until you're pregnant and then you're reading labels and it says, if you're pregnant or breastfeeding, do not take. And I'm like, how much of that is because it's harmful or because you just don't know, and to save your butts, you just put that so that, because you don't actually care to do the research to study it, to actually know conclusively with scientific data, is this true or not? And then you end up actually hurting people because then there will be things that you haven't studied that come out and that are detrimental, right? And so I think it comes from a place, not that it was inherently kind of bad to think about. It was probably, those decisions were probably made thinking that they were going to be safest, when in reality, they actually ended up hurting women.
I think so. I think having unknowns are just hurting us, right? Because the less you know, the less you know how to help us, right? And the less you know how to like support us and I guess just improve our well-being and then that of our children, because if we're pregnant, that's when we're the most vulnerable, because we're both emotionally and mentally vulnerable, but then, physically we're carrying another, a child, we're carrying life.
Yeah.
And I think it's so important for there to be, I guess, just more knowledge and more research surrounding women's health and specifically like pregnancy and everything pertaining to that, right? I wanted to ask you, going back to, fertility specifically, is there anything that women and men could do to preserve their fertility for longer?
Well, other than things like egg freezing, which can kind of preserve fertility for a lot of people, generally just having healthy lifestyle is really important. So we know that there are certain things that are very, very harmful. Smoking is one of them. So we know that people who smoke cigarettes, for women, they go into menopause like 4 years earlier, so their reproductive lifespan is going to be shortened. The metabolites that are found from cigarettes are found in the follicular fluid, which is the fluid that surrounds the egg. It can impact the fallopian tubes. It can really impact fertility on the female side. And then on the men's side, can hugely disrupt spermatogenesis, the development of sperm health, the ability of a sperm to fertilize an egg. And that's not even including like secondhand smoke that people are exposed to. So that's kind of one major thing that somebody does have control over. Not that if you're a smoker, it's easy to stop, but it is something that can majorly improve fertility. And I see a lot of patients who are smokers who everybody knows, so yeah, smoking is bad for you, But when it comes to fertility, it's something that it's very actionable. And I've seen a lot of people who have struggled to stop smoking. And then when they find out that it can potentially help them regain some of their fertility potential, because stopping does help, they're able to kind of stop, which is amazing. And feels great kind of for overall life, super heavy alcohol use is not great. Caffeine is, continues to be studied, but more than a cup a day, like 200 milligrams of caffeine, could potentially increase the likelihood of miscarriage. So there are kind of lifestyle things that I think can sort of help. Men have the potential to make new sperm forever, but there is a decline in fertility as men get older too. It's not like they're kind of off the hook with age, but kind of that decline in number of eggs is a process that unfortunately can't be fully stopped.
Okay, thank you. So I have one question that sort of I'm just curious to know your thoughts. In an ideal world, right? What do you see changing in terms of kind of there being more options out there for both women and men, right? But specifically, potential for men as well, in terms of fertility and all of these issues?
That's a really great question. So for male fertility workup, we do the semen analysis, right? The semen analysis looks at sperm count and sperm motility and morphology, which is what the sperm looks like under the microscope. The semen analysis literally hasn't changed in so many years. So we see all of these kind of advancements with blood work and things like that. I think that we probably need a little bit better testing for male fertility rather than just that kind of very crude information that we've been able to get for a very long time. There are newer technologies like something called DNA sperm fragmentation. These are kind of in their, not in their infancy, they've been used, but just other things that can look for the potential for fertilization of the sperm. So can the sperm fertilize an egg? And I think we just probably need a bit better testing rather than, we look at those 3 or 4 parameters and say male factor or not male factor. We can probably do a little bit better about looking at whether that sperm has the potential to fertilize an egg, because that's really the question that we're trying to ask, So, yeah, I think that that's something that can definitely be helpful in the future. And then I think we just need to continue to educate people about their fertility, and what things matter, what things maybe don't matter as much, and kind of when to get an evaluation is really important.
Yeah, thank you. This is all such great information. I, like you, Ray, didn't struggle with fertility. I don't know if it's how much of the genetic aspect, right? My mom never struggled. I don't know. Many Hispanic women don't struggle. We seem to be overly fertile, actually. I both pregnancies, right? I was told that if you breastfeed, exclusively, your period won't come back for like 8 months to a year. And I was like, oh, that's great. And nope. 6 weeks postpartum, both times I got my period. And I guess that's a better option because I knew I was ovulating, right? What happened to my mom was that she didn't get her period and she was ovulating. And so my siblings are 16 months apart.
Oh my goodness.
Thankfully that I did get my period, and I was, notified that you're ovulating, yes, just so you know. But yeah, I think it's such an important topic, and it's important for me as, also just a mom, and to know of struggles that other moms face, or other, women who want to become moms and men. And it's important to educate, I think, the society at large, right? Even though you maybe don't have that specific, issue, you're not faced with that hardship. Many people are. So yeah, thank you so much for educating us. And one last question about like your actual, career and the work you do. You were trying to make it more accessible, right, in other parts of the world. And I want just to hear a little bit more about that and those projects.
Yeah. So kind of access to fertility care on a whole is something that has been important to me since I learned about fertility care. Mm-hmm. When I was first exposed to kind of the world of infertility, I practiced in a few different places. I did some rotations out in California and Massachusetts and New York, and found that in a lot of places, the population of people who had access to fertility services was very homogenous. Like everybody was the same, right? Mm-hmm. Which means that there's a huge number of people who are not getting the care that they need. Mm-hmm. And so that's both in the U.S. and outside of the U.S. So, a few things that we're doing are we have an association with Guyana, and we went down to GPHC, which is their kind of public health system there, to assess the fertility needs, to try to incorporate kind of better fertility services in that country. And there's a doc from Guyana who's with me now, who's training to hopefully be kind of one of the kind of premier fertility docs there, so that they can continue to treat the patients that require fertility care there. And then here, I publish a lot about kind of differences in access to care. One example is that very often there are BMI cutoffs for fertility treatment at different clinics. And while that by itself doesn't sound like it's inherently a bad thing, BMI is actually a horrible predictor of health. BMI as a parameter was developed from white men. Mm-hmm. So when you apply it to women or women of color, it's just not a good predictor of health. There are better ways that we do it. And so when we use that as a parameter to, say, allow people to do IVF or not, what you're doing is you're expanding the disparities in access that already exist, right? We know that non-white women come to the office later, like they're referred later, they have later appointment times. It takes longer for them to kind of show up at the door and then get into treatment. And then when we're imposing additional barriers in access to care, you're just widening those disparities. Mm-hmm. And so that's kind of one of the things that we're doing, just sort of here, publishing about it, just getting the word out that maybe we need to reevaluate what our protocols are, mm-hmm, as a whole, because some of these parameters are decreasing access in ways that are not fair, right? Not equitable. Mm-hmm. So, kind of those are the things that I'm doing. And then, I also see a lot of cancer patients with fertility issues, and trying to expand fertility preservation options for young girls with cancer who can't do egg freezing by starting an ovarian tissue freezing program at Northwell.
Wow. Yeah.
So it's a little separate, a little different, but still expanding access to fertility services.
That's incredible. And how do you go about, I guess, expanding access when it comes to like the cost and health insurance and all of those aspects?
That is a great question. So when you talk about barriers, there is no greater barrier than the financial one. So you can have your doors wide open, and if you have a patient or a family or a couple that can't afford it, the doors may as well be closed, Yeah. So for the ovarian tissue freezing, that is something that is for younger girls who have usually a cancer diagnosis where they have to start treatment pretty quickly. And they can't do egg freezing because they are not pubertal yet. They haven't had their axis hasn't been turned on. but you can remove an ovary and freeze it in strips and then reimplant it in the future when she wants to have a child. And it's no longer considered experimental. There have been over 200 births worldwide from this technology. But the issue is, even though it's no longer considered experimental, insurance companies aren't paying for this, right? It's still considered kind of experimental in their kind of umbrella of insurance. And so just trying to, bring awareness to it, hopefully have people kind of have a, to donate for this cause is something that we do. In my ideal world, we would have no financial barrier. People who needed fertility preservation, especially for a diagnosis of cancer, would be able to have the funding that they needed for it. Insurance companies need to increase their fertility benefits. That's going to be the end of the road, I think, hopefully. But until that happens, have to be other ways that we can just, work with people to get there. When people are doing elective egg freezing or planned egg freezing, oftentimes they can plan it in advance. You have you're going to do an egg freezing cycle, you're going to do it in 3 months. And sometimes people can save up and they can afford it. But imagine being a cancer patient or a kid who has cancer, and your family is getting this devastating diagnosis that your child has cancer. And not only that, but the treatment that is going to be used to treat the cancer can save their life but cause permanent infertility. And we've got this great technology that could potentially help. But by the way, it's $20,000 and we need it tomorrow, right? To me, it's just if we're able to offer this technology, we have to find a way for people to be able to access it. And so that is something that I'm spending a lot of time doing now, in addition to just kind of seeing patients, is just kind of expanding fertility access. We have these amazing technologies and we have to be able to find ways to have people use it.
Yeah. Amazing. I mean, Randi, you've been not only just such an inspirational person to get to know, but, I'm so honored to have you here as a guest, and that everyone's, listening is able to benefit from listening to you.
Thank you.
And yeah, we need more doctors, like you who care about having, their work be accessible, right, to people. Because that's the biggest barrier, I think, in this country, the access to healthcare that, is just, it's so important. It's so important for that to be implemented, right?
Yeah.
So anyway, I just want to thank you a million times. And if there's anything else that you want to add, about your work, what you're doing, this is your time to do so.
Oh my gosh. Well, thank you. It's to me, I have the best job in the world, and I love to talk about it and just kind of get out there what we're doing and what we can do. And thank you for having me. It was really an honor.
Thank you. Bueno, mi gente, gracias, and thank you for listening to this episode of the Unaparent podcast. If you enjoyed this episode, be sure to subscribe as we release a new episode at least every month with an exciting new guest. Be sure to also follow us on Instagram for all the Unaparent content you never knew you needed.